everyone. My name is Emma, and I'm one of the P2I2s, hopefully P2I3s, a few, I guess, in a week. I'm introducing our wonderful visiting med students today. The first one is Alvina Liang. She's coming to us from Vanderbilt University. Her title of the talk is going to be Understanding Health Literacy Barriers in Eye Care. And a fun fact for her is that she has a twin brother who just graduated law school.
Hi, everyone. My name is Alvina, and I'm a fourth-year medical student from Vanderbilt University. And my grand round talk today will be on understanding health literacy barriers in eye care. And before I start my presentation, I just want to thank my mentors at Vanderbilt, including Dr. Gangaputra, Dr. Brown, and Dr. Chomsky for helping me put together this presentation. Right. So I want to start with a patient case. We have a 56-year-old male with advanced glaucoma who presented to the Nashville VA as a same-day add-on with a chief complaint of worsening vision and in need of medication refills. Really quickly, through his history of present illness and past medical history, he was monocular with left eye being NLP and right eye with advanced primary open-angle glaucoma. He also had a very complex medical and social history with being homeless and having chronic kidney disease and anemia. During the intake process, when we asked him about his current medication use for his glaucoma, he was using words like, oh, I think I used the one with the pink top, and I used Timolol. I think it's been a while since I've used it, but I'm not sure when I last used it, and I use that one occasionally. So to me and the residents, it was clear that he was having trouble recalling what medication he was using, including the names, the frequency, and also when he should use these drops. On exam, his visual acuity was right eye 2400, pinholing to 2200 -1, and his left eye was NLP. His IOP was within normal range at this visit. And we deferred additional testing due to him unable to perform like visual fields and OCT because he was not really understanding the instructions that we were giving him in clinic. For his slit lamp exam, he had meibomian gland dysfunction with lash crusting in both eyes, mild PE in both eyes with endopigment in the left. He also had an irregular and correctopic iris with superior peak in the left eye and some cataract in both eyes. For a dilated fundus exam, we got no view in the left, and in the right eye, he had a 0.99 cup to disc ratio with a blunted macula and attenuated vessels. So this slide shows the most recent OCT imaging that we got, which is in May of 2022. And this was 3 years prior to this visit where he had presented at the Nashville VA when we saw him. So very quickly on the right-hand side, the ganglion cell analysis reveals very severe thinning in both eyes, especially in the left. There's like very small numbers. The red areas on the deviation map highlights extensive ganglion cell loss. And then on the left-hand side shows the RNFL analysis showing, again, very diffuse nerve fiber loss in the right eye. So these findings confirmed advanced structural damage consistent with his clinical picture that we see today. So this is a very busy slide, but there are just a few things I want to highlight without belaboring every single detail. But this is a timeline of this patient's care at the Nashville VA going all the way back to 2017. And here, the red boxes highlight visits where non-adherence or confusion about his medications or care was documented in his clinical notes. So on this slide, we can see that in May of 2022, non-adherence was suspected in his notes, and again in July of 2022, and then March of 2023, we discussed like the urgency of adherence. So the blue boxes here represent moments when the clinical team attempted interventions, and this can include using teach-back methods with the patients during the clinic visit, providing written drop instructions, and also simplifying his drop regimen. All of these efforts to try to improve his understanding and his engagement with his care. However, despite these efforts, gaps persisted and surgical care in the right eye was discussed for his glaucoma. Okay, so for our assessment and plan, our assessment is end-stage glaucoma in the right eye with absolute glaucoma in the left. We also, at this visit, we decided to resume all of his glaucoma medication regimen and refill all of his meds. And we also decided to schedule very close follow-up of within like 1 month to monitor for his intraocular pressure. And we also discussed surgery options for his right eye. So cases like this illustrate the very critical but also invisible role of health literacy in our patient care. They raise a very important question of how well do we really understand our patients' capacity to absorb and act on health information that they were given in clinic. So this question led us at Vanderbilt to step back and examine the bigger picture. Since 2020 at the Vanderbilt Eye Institute, we've been investigating the current landscape of health literacy among our patients, including how they prefer to learn, how confident they feel navigating health information, and also where the greatest gaps may exist. So over the next few slides, I want to walk you through what we've learned so far, what has surprised us, what patterns we see are emerging, and also how this work might help us inform more effective patient education in our clinical work moving forward. So I want to start with a quick background slide. What is health literacy? So health literacy is defined as the ability to find, understand, and use health information to make informed decisions about one's care. And it is very essential for navigating the healthcare system, communicating effectively with providers, and also managing chronic and complex conditions. So low health literacy has been linked to poor understanding of medications and their diagnosis, lower adherence to medications and follow-up, and also worse visual outcomes in glaucoma, AMD, and diabetic retinopathy. It has also been reported in literature that it's estimated that more than 1 in 4 adults in the US have inadequate health literacy. So this means that in our day-to-day clinical interactions, we are more likely than not to see a patient or more than one patient with lower health literacy. So for our research project, we have 2 main aims. The first is to characterize the health literacy profile among patients in our comprehensive and also subspecialty ophthalmology clinics at the Vanderbilt Eye Institute. And the second is to see if there are any associations with health and health literacy. So our study design, this is a retrospective cross-sectional study. The surveys were conducted and implemented between January of 2020 and to April of 2024 within a 4-year span. Our data sources, so health literacy was assessed via a brief health literacy screen, which later I will explain. And we also collected EPIC data on demographics, visual acuity, and chronic conditions in our patients. Our participants included adult patients from our comprehensive clinic and also subspecialty clinics, including patients from neuro-ophthalmology, retina, glaucoma, cornea, and oculoplastics. And for our analysis, we decided to use a Bayesian mixed effects ordinal regression with covariates including age, sex, race and ethnicity, primary language, highest level of education attainment, clinic type, and any medical or ophthalmic diagnosis, and lastly, best corrected visual acuity. So what is the brief health literacy screening? So this is a 3-question survey scaled on a Likert scale, so from 1 to 5, that we ask every single patient during the study period, during our intake process. So each patient will have a summed up score of each the 3 questions. So each patient will have a score between 3 and 15. And the 3 questions are, number 1, how confident are you in filling out medical forms by yourself? Number 2, how often do you have someone help you read hospital materials? Number 3, how often do you have problems learning about your medical conditions because of difficulty understanding written information? And a higher score indicates better health literacy through the survey. And just very quickly on the right-hand side, this is fully integrated in our EPIC intake process, and all of our ophthalmic technicians were trained on how to implement this survey during the intake process. Okay, this is our patient or participant characteristics, and this is a lot of information, so I'll just briefly mention a couple highlights. So our sample included over 19,000 adult patients across 6 clinic types, with most seen in comprehensive or glaucoma clinics. Our patients were generally in their 60s, but neuro-ophthalmology skewed a little younger with a mean age of like 52. The majority of our patients were white, English-speaking, and had at least some college education, even though glaucoma and neuro patients had more racial diversity and slightly lower educational attainment. So this is a forest plot showing the results of key demographic or factors linked to inadequate health literacy. So this is an odds ratio of showing how likely they are to have adequate health literacy. So a score greater than 1 means they're more likely to have better or adequate health literacy, and a score lower than 1 means that they have an odds ratio of being at risk of having lower health literacy. So after adjusting for our covariates, certain groups had significantly higher odds of inadequate health literacy. These groups include being male, being of Hispanic ethnicity, being of Black or Asian race, and those with less than high school education, being a non-English speaker, and those with poor vision or chronic eye disease, including diabetic retinopathy, macular degeneration, and glaucoma. When we compare patients within subspecialty clinics, we found that patients seen in cornea, neuro, and glaucoma patients are more at risk for having lower health literacy when we compare them to comprehensive clinics. So why do these findings matter? So these findings suggest that health literacy gaps may be missed in a fast-paced, high-volume subspecialty setting, and understanding patient capacity to process health information is crucial for medication adherence, informed consent for surgeries, and long-term outcomes and follow-up. And this also highlights the need for clinic-specific patient education strategies. Like many large EMR-based studies, ours have very important limitations. So first, our sample lacked diversity. It was predominantly white and English speaking, which limits how broadly we can generalize our findings. Most of our patients were from comprehensive clinics, making up around like 80% of the cohort. And it is also important to acknowledge that at Vanderbilt, we rarely see uninsured or underinsured individuals. So this probably means we likely miss more vulnerable population groups. Also, health literacy was self-reported, which may introduce potential inaccuracies and bias for our methods. And lastly, this is a single institution study, which may not reflect practices or populations elsewhere. Okay. So for future directions, our group is very interested in exploring the relationship between neighborhood level risks using the CDC's Social Vulnerability Index and health literacy. We are hoping to build a mediation model to examine how social vulnerability and health literacy together impact visual outcomes. These are my references. And I just want to thank my mentors again for helping me and mentoring me through this project. And this is like an optional discussion question for everyone, which is, do you have any specific ways in which you try to address health literacy in your clinics? Thank you.
All right, great job, Alvina. It's a really important topic that affects a majority of our patients, so it's important topic that we need to think about a lot. Our next visiting student is Mira Shoukry, and her topic is Global Ophthalmology, the Fellow Experience. She's coming to us from Mayo Clinic, and her fun fact is that she's lived in 3 different countries, which is pretty cool.
Hey, good morning, everyone. First, I just want to start by saying thanks for having me, and thanks for everyone who's made this experience so wonderful so far. So yeah, today I'm going to be talking about a project I've been working on with my mentor, Dr. Ashley Bernheisel, that talks about the Global Ophthalmology Fellow experience. So a bit of background first. So global ophthalmology is definitely a field that is quickly growing over the years, and it has evolved into something that is not only focusing on service delivery in resource-limited areas, but also now encompasses research, training, sustainability, community partnerships, etc. And the ultimate shared goal is to reduce the global burden of eye disease and preventable blindness. So as awareness for global eye care needs grew, global ophthalmology fellowships were established to sort of hone in the specific skills and knowledge necessary to engage with under-resourced communities, both locally and abroad. This graph here just is a visual representation of global ophthalmology fellowships over time. So with the first one being established in 2008, which is of course the Moran. And then since then, 7 more fellowships have been established. So historically, fellows have been able to kind of build their fellowship experience in a way that kind of aligns with their goals, which is great, but it has led to a lot of variation across fellowships. And that being said, the purpose of this study was to try and characterize the global ophthalmology fellow experience overall, try and identify areas for improvement, and address any challenges that a fellow might face both during and after their fellowships. So the design of the study, this was a 28-question web-based survey distributed to all alumni who completed a formal global ophthalmology fellowship between 2008 and 2022. The survey itself was 25 closed-ended multiple choice type questions and 3 open-ended questions. Responses were collected using Qualtrics, incomplete surveys were excluded, and then in terms of data analysis, the quantitative responses were summarized descriptively, and qualitative answers were reviewed by the study team, and recurring themes were identified and described. All right, so what did we find? So first, here are some results that tell us a bit more about our survey respondents. So we got an 89% response rate, which is 33 out of 37 people. 20 of those respondents reported completing another subspecialty fellowship in addition to global ophthalmology, with the most common one being cornea and refractive, followed by oculoplastics and retina, peds and glaucoma, anterior segment, and ocular oncology. 12 fellows also earned a master's degree, with the majority completing them during medical school. The degree concentrations, it's interesting because it varied a lot from public health to environmental engineering to business administration. But 92% of the fellows that completed a master's degree said that it was helpful in their global ophthalmology work. And then now getting into the global ophthalmology fellowships themselves, 73% of respondents said that learning objectives for their fellowship were made clear to them. And these next slide are kind of a summary of the curricula according to the fellows. So this first graph shows a breakdown of the topics that fellows were taught during their fellowship, with the majority of fellows saying they were taught surgical ophthalmology skills. And then on the other hand of the spectrum, fewer fellows reported being formally educated on things like social determinants of health, disease prevention, and health economics. And then similarly, this is a breakdown of the ethical concepts that fellows were taught. And it seems like the majority of fellows received education on all of these topics, with almost all learning about respect for local norms, customs, and priorities, avoiding service-only initiatives, and being accountable to local providers and partners. And then on the other hand, some alumni felt less familiar with obtaining consent in a foreign country and operating outside of their normal scopes of practice. This is a representation of how fellows felt like their time during fellowship was spent, with on average 28% of the time was dedicated to service delivery, followed by clinical training of other professionals, then non-global ophthalmology duties at their home institution, research, etc. Okay, so let's talk a bit about the fellows' experiences after fellowship now. So 70% of participants agreed that completing a global ophthalmology fellowship has been seen as a valuable, positive experience by potential employers. 27% were neutral, 3% disagreed with that statement. 88%, so about 29 respondents participate in global ophthalmology work post-fellowship, with the majority dedicating about 1 to 20% of their professional time to global ophthalmology. And then of those, 72% report that all global health work is volunteer or unpaid work, 21% indicated that it's partially funded, and 7% receive full financial support for the global ophthalmology work that they do. So all but one respondent expressed wanting to spend more time doing global ophthalmology work. And when asked what resources or support would enable them to do so, 19 mentioned needing more administrative support, 18 mentioned more financial support, something that would be beneficial, 11 mentioned the need for peer collaborators, and then 10 people selected other, but of those 10, the vast majority cited time. They just needed more protected time to dedicate to global ophthalmology. Okay, this is the last bar graph I'm going to show you, I promise. This is a breakdown of what kinds of global ophthalmology work the fellowship alumni do now. So clinical training of ophthalmologists and eye health personnel was the most commonly reported activity, followed by service delivery and then research. Okay. And then now we're getting into the sort of more free response questions that we asked. So one of them being, knowing what you know now, are there any concepts or learning objectives you wish had been covered during your global ophthalmology fellowship? And a lot of the respondents highlighted the need for a more structured curriculum. And then some direct quotes here. I had no official curriculum and learned everything circumstantially. This was fine, but would have been nice to have an initial curriculum as a jumping off point. I wish I would have sat down with my program director and asked for formal training and specific objectives for the year. I didn't know I was allowed to ask for formal training in all the areas listed. So specific objectives would have been helpful for me. And then another question we asked is, in what two major ways has your global ophthalmology fellowship impacted your professional life? And the vast majority of answers here actually had to do with professional networking. So a lot of people felt that, shared the sentiment of much of my professional peer group and societal involvements are driven by connections made during my global ophthalmology fellowship year. And then some other answers we got here. The fellowship enhanced their surgical skills, confidence, adaptability. And then the Global Ophthalmology Fellowship also seemed to reignite people's passion for practicing ophthalmology with increased job satisfaction. And a lot of them cited less burnout as well, which is cool. So just some conclusions. The results of this survey highlight that there's such a variety between fellowships in global ophthalmology, and learning objectives are not explicitly presented 100% of the time. A lot of fellows express a desire for additional training in key competencies, including research, resource management, program development. So it would be helpful to have a group of experts work together to create a core curriculum for global ophthalmology fellowships. But the goal here would not necessarily be to make the experiences completely uniform, but rather just to have the fellows feel confident that certain standards of education will take place regardless of which fellowship they choose to complete. And then we did notice a discrepancy between the desire to participate in global ophthalmology and those who actually still do participate in global ophthalmology work post-fellowship. And then related to that, some fellows might benefit from additional support from programs, potentially finding places, employment that might encourage more global ophthalmology work, or potentially focusing on like education surrounding how to negotiate more protected time or financing for global ophthalmology work in their contracts as well. And then I just want to thank all these people who were a part of the study and allowed me to be a part of it as well. And yeah, thank you again for having me here. And welcome any questions.
All right, wonderful talk, Mira. Our last but certainly not least student is Kenneth Hahn. He also goes by Ken, and his topic is going to be Mind the Vault, ICL complications and nomograms. He is coming from the University of Arizona, and his very fun fact is that he's in a rock band, and his rock band's called the Hardwood Horse. Look them up on Spotify.
Hi, good morning, everyone. Thank you again for having us. It's a real honor to be presenting at Moran's Grand Rounds. And thank you, Eamon, for the kind introduction. Didn't realize today would be publicity for my terrible garage band, but we appreciate it. Today I'll be talking about ICL complications and nomograms. So starting off with some background on ICL. ICL stands for implantable columnar lens. It's a phakic posterior chamber IOL that can be used as an alternative to corneal refractive surgery. One important measurement in ICL is vault, which is the distance between the posterior surface of the ICL and the anterior surface of the crystalline lens. This is an important measurement because complications arise when vault is too high, namely pupillary block and angle closure glaucoma. And when vault is too low, it can result in anterior subcapsular cataracts. Because of this, numerous nomograms have been developed to help try to predict postoperative vault, as well as to provide recommendations for ICL size. These nomograms utilize various preoperative parameters in their function, and we'll touch back on that a little bit later in the presentation. So starting off with a patient case, this was a patient that Dr. Zog was consulted about. We have a 22-year-old female who's a high myope presenting for ICL complication. Past medical and surgical history are non-contributory. She's on no medications. Family history is significant for a father with glaucoma. And on exam is pretty unremarkable. Cup to disc ratio is 0.5 and pressures are normal. These are her preoperative measurements. Ultimately, 13.2 millimeter EVO plus Visian toric lenses were implanted in both eyes. She was provided with the standard instructions to continue her antibiotic drops and to taper her steroid drops over the following month. On post-op day 1, her vision is good. However, her pressures are a little bit high at 24 and 26. And vault is on the higher end of normal at 766 and 697. And the normal vault that we aim for is around the 250 to 750 range. Because of this, bromonidine was added to her regimen. She comes back to clinic on post-op day 5 with this sudden onset severe pain in her left eye, as well as blurred vision down to 20/40. Pressures are elevated at 30 in both eyes. Interestingly, though, vault is still within the reference range. So she was added on Combogam and latanoprost because of this. A week later, her pressures remain elevated and Diamox is added as well. At this point, would anyone like to propose any differentials? All right, if not, I can go through a short list that I created here. So angle closure glaucoma, pupillary block, aqueous misdirection, choroidal effusion are all possible. But despite all of the framing I just did in the previous slides, this was actually just a simple case of ocular hypertension secondary to steroid. So this patient's pressure normalized quickly with the steroid taper and didn't require any invasive intervention like PI or ICL removal. The main takeaways from this case are that ICL and other refractive surgery patients are often at risk for the perfect storm for steroid responsiveness in terms of IOP. They're often myopes. They may have a family history of glaucoma like our patient had. They experience pupillary dilation during surgery, and they may have some retained viscoelastic materials. Because of this, close post-op follow-up and management can help manage the pressure and prevent any unnecessary intervention. And in this case, post-op vault actually helped rule out angle closure and pupillary block in our case. And despite the fact that this was not a direct case of ICL complication, I still thought it was a good example to highlight the fact that vault is an important post-operative parameter, and having nomograms that accurately predict this measurement is also important. So this leads me to a paper I worked on with Dr. Moshafar, comparing multiple nomograms that are trying to predict post-operative vault. Our main question was twofold: which ICL sizing nomograms are the most accurate, and which preoperative parameters are most important to be a part of these nomograms. So we performed a retrospective chart review of around 200 eyes at a single surgery center who underwent ICL implantation. And we compared 12 of the most commonly used and widely accepted nomograms on the market. This included the STAR nomogram, which is the manufacturer's own. So of the 12 nomograms we compared, 6 of them provide postoperative vault predictions. Of the 6, 4, Kim, Rocamora, Russo, and Reinstein, were more accurate at predicting postoperative vault with a mean absolute error of about 250 microns. And these were more accurate than KSV2 and Nakamura V3, which had an average mean absolute error of 750. Along similar lines, those 4 nomograms also performed well, being able to predict at a frequency higher at within 50 microns, 100 microns, etc., compared to KSV2 and Nakamura V3. But this is not a dig at those 2 nomograms. Rather, those 2 nomograms were developed in Asian countries, and we propose that since our study population was mainly Caucasian, perhaps those are better suited to different eyes. Finally, we ran a univariate linear regression comparing various preoperative parameters and postoperative vault. And there's a lot of numbers on this slide, but basically boils down to the fact that anterior chamber depth and anterior chamber angle were the most positively correlated with vault, and sulcus to sulcus lens rise and ciliary body inner diameter were the most negatively correlated with vault. And I've included some pictures of ultrasound biomicroscopy, which is how we obtain a lot of these measurements. So in conclusion, the Reinstein, Rocamora, Russo, and Kim nomograms were the most accurate for predicting vault. And among the preoperative parameters, anterior chamber depth, ciliary body inner diameter, sulcus to sulcus lens rise, and anterior chamber angle had the strongest correlation with vault. And these should definitely be incorporated in any future nomograms that are developed. Also, future directions, AI is currently being incorporated into various nomograms. One example being ICL Guru. I've included a printout of what that looks like on this slide. Here are my references. Thank you to Dr. Zog and Dr. Jardine for looking over my slides, and Dr. Moshafar for allowing me to present our project. And thank you again for the opportunity. Happy to take any questions.